Are you a healthcare professional working with breastfeeding infants? Wish you knew more about assessing and treating tongue ties? Earn continuing education credits and transform your practice with the Professional's Guide to Tongue Tie in the Breastfeeding Infant. It's perfect for any practitioner who works with infants and their mothers, especially those working through feeding challenges. Learn to identify who needs treatment, build a qualified care team, and provide holistic care options. Discover the ins and outs of frenotomy, including procedure preparation and best aftercare practices. By the end, you'll be confidently supporting breastfeeding families armed with the latest protocols and be part of an interdisciplinary community of experts just like you. Tongue ties are nothing new, but the right way to assess and treat them is. Ready to make a real difference? Join now and become a tongue tie expert. Sign up today at tonguetieexperts.net/professional and become the evidence-based resource that your community needs. To show my gratitude, I'm offering you a special discount as a podcast listener. Use code PODCAST40 to save 40% off today. When I began to work in this field, I quickly realized that school didn't teach me enough about tongue tie. I wanted the opportunity to learn firsthand from an experienced professional. I had so many questions. Can you relate? Good news. I've created the Professional's Guide to Tongue Tie in the Breastfeeding Infant just for you. You'll get 4 recorded video modules, downloads to share with your patients, admission to a thriving multidisciplinary community for networking, sharing, and continued learning, and 4 LSERPs. All the details are on the website at tonguetieexperts.net/pro course. Use code PODCAST15 to save 15% off this and all of my courses. Can't wait to see you in the group. You're listening to the Tongue Tie Experts podcast, a weekly program providing information and support for those families impacted by tongue and lip tie and the professionals caring for them. I'm Lisa Palladino, a midwife and a lactation consultant with over 30 years of experience. If you are a parent looking for answers or a professional who is curious to learn more than what you learned in school on this topic, welcome. This podcast is for you. A gentle disclaimer. Please do not consider anything discussed on this podcast by myself or any guest of the podcast to be medical advice. The information is provided for educational purposes only and does not take the place of your own medical or lactation provider. Thank you. Welcome back, everyone, to the Tongue Tie Experts podcast. I'm your host, Lisa Palladino, and today I am honored to have as a guest Dr. Kevin Boyd. And when you hear his resume, you'll understand why I'm honored and thrilled. Dr. Kevin Boyd is a board-certified pediatric dentist in Chicago who holds a Master of Science degree in Human Nutrition and Dietetics. He teaches in the Pediatric Dentistry residency training program at Lurie Children's Hospital and also serves as a dental consultant to their sleep medicine service. Dr. Boyd is an adjunct assistant professor in the Department of Anthropology at the University of Arkansas, mentoring PhD research, and also serves as a visiting consulting scholar at the University of Pennsylvania's Museum of Archeology and Anthropology, where he is collaboratively exploring a hypothetical relationship between changed dietary practices since the Industrial Revolution and diminished human dentofacial development. He lectures worldwide on the topics of early childhood malocclusion, pediatric sleep breathing hygiene, and evolutionary oral medicine, Darwinian Dentistry. Welcome, Dr. Boyd, and thank you so much for being with me here today.
Please call me Kevin. It's a nice title, the doctor, right, but yeah, we're all professionals here and friends.
Excellent. So Kevin, the things that stand out for me, as an IBCLC, I'm also a midwife and I study functional medicine. So the nutrition, the anthropology, all of these aren't words that you usually hear associated with a dentist.
Not yet.
Can you explain your evolution?
Yeah, actually, that's a good way to put it. I attended an all-day symposium at the University of Washington in Seattle during my tenure as a brief stint as a program director in pediatric dentistry under the UCLA umbrella of pediatric dentistry residencies. They had 4 of them at the time, and one of them was in San Diego at Rady Children's Hospital. So I commuted from Chicago weekly for about a year and a half directing that. And toward the end of it, they had some money in the department that needed to be used or it would be lost. So I was able to go to Seattle from San Diego and attend this all-day symposium on nutrition and dental caries. Well, it was interesting because the word anthropology was in the description. It was Philippe Houjoul. He is a epidemiologist and a periodontist, academic at the University of Washington, and had proposed a theory that tooth decay was something that didn't really exist in humans until they discovered how to plant cereal grains, wheat and corn and all that stuff. And that's when tooth decay starts to enter into, well, I thought that is nonsense. That I would have learned that in dental school, right? Oh, no.
Right.
So it was true. Like no cavities in humans for hundreds of thousands of years. That's how long we've been around. I didn't even know how long we'd been around, right? But we go all that time without tooth decay. And then, bingo, 10,000 years ago, it starts. Well, I became curious about what about malocclusion? There was no malocclusion till about 300 or 400 years ago. So that's really what started it.
Yeah, for those who listen to the podcast too, because we have both professional and parents who listen. So just define malocclusion.
Yeah. Malocclusion just means poorly aligned jaws and teeth. Poorly aligned jaws, meaning they don't match up, and usually one or both jaws are too far back in the face. The face is retruded. It's gotten pushed back over the last 300 or 400 years. And the teeth have gotten crooked. They're used to not, it just didn't exist. Everyone used to have their wisdom teeth fully erupted. If you didn't have
and there were no braces and there was no need for braces.
There really wasn't. And
right.
Another, theory or a hypothesis that we're pursuing is that if a child didn't have a perfect shaped jaw, meaning perfect for what? That the tongue can fit up in the roof of the mouth all the time, except when they're eating. That's the only time that the tongue should be not in the roof of the mouth. For swallowing, it does have to be, but not for chewing. So what happened was jaws gradually started to get pushed further back, and the faces started growing longer and narrower. And that, was something that just did not occur if you didn't have a foundation. Before you were 6 years old, you did not survive childhood. And that, pretty much meant that if a kid wouldn't live long enough to develop malocclusion. That's really what happens. If a child's mother died, couldn't nurse, there was a famine, they couldn't baby-led wean or anything like that, they wouldn't live long enough so that the jaw would, not develop properly. So it was required to survive childhood, to have perfect jaws.
I don't know if my thinking is following correctly, but then you're thinking about evolutionary, that child would not reproduce because they didn't survive.
Right. They
So
wouldn't. It's called.
only good, right?
Yeah. It's
Go
called
ahead.
evolutionary fitness, which doesn't have. It's not physical fitness. Evolutionary fitness means that you would have lived long enough to pass on your genes to reproduce. Okay. So
Mm-hmm.
any child that did not have an ideally shaped and functioning jaw and face and tongue and airway, they would not have achieved evolutionary fitness. They would not live to the age of reproduction, which, 13, 14, and 15 is what our ancestors, that's when they would mate and reproduce.
So many of you have asked what to do to prepare for frenotomy that I decided to share part of my Parent's Guide to Tongue Tie with you for free. The Preparing for Frenotomy checklist is one of the most popular with parents and professionals. The day can be stressful, but if you are ready, everything can go smoother and you will feel calm knowing that you are prepared. You can download this free checklist at bit.ly/readyforfrenotomy. You can find this link and other links to all of my courses and freebies in the show notes. I hope you find this helpful. So we survived, those of us, meaning those humans who had the right structure, were able to breastfeed, develop their mouth, their jaws, their whole cranium appropriately, reproduced. So our evolution favored good shaped, properly shaped and healthy shaped
It
faces
not only favored it,
until a certain point.
it demanded it.
Okay.
It just absolutely was not
Mm-hmm.
possible. And there wasn't a whole lot of
Mm-hmm.
variability. I mean, now you see long faces, short faces, uh, lower jaws that are too far back, upper jaws, underbites. You see all those things. Nobody had any of those. Now everyone
Mm-hmm.
actually had brown eyes at one time. Blue eyes doesn't enter into the human condition till maybe several thousand generations ago. Well, in terms of how many generations of
That's
humans have
interesting.
lived. Well, yeah, isn't it? But there was still,
Yeah.
there's still variability. I mean, all robins look alike to us when you look at birds, but they don't to each other. They can pick up subtle
Mm-hmm.
variations in each other. And
Mm-hmm.
everybody had room for their wisdom teeth. And they had to have the foundation that would be conducive to wisdom teeth coming in not only perfectly, but with space behind them. And so
Wow.
so lack of wisdom teeth is sort of an indication of what has happened to our jaws and faces. Charles Darwin wrote
Mhm,
about that in the 19th century, and he even
mhm.
mentioned in one of his books, in the 1860s, oh my gosh, in America, some dentists are actually pulling out back teeth to make them fit in the jaws, and he attributed it to soft diet. Charles Darwin, good observation.
Wow,
He was right
I didn't
again.
know that.
He didn't get everything right, but he got that right.
Right, right. So one of the things that you mentioned in passing when you were talking about that opportunity to go to that lecture is the idea that you didn't learn it in school. And I
Right.
say this all the time when I'm talking to people. Like why doesn't everybody even know what I know even about just breastfeeding? It's
Yeah.
because we didn't learn it in school. And I applaud those of us who are professionals and an ever-growing bunch of us, thank goodness, who are realizing that there's more to know than what we learned in school. Because if you stop with what you learned in school, it's a dead end, and you're not going to be able to help people, and we're going to perpetuate this unhealth of the generations as we go forward, which is kind of scary. So we didn't learn it in school. There's lots of stuff that we know that we didn't learn in school, right? So we have to keep learning,
Oh,
and
and I
it's
tell
one of
my
the reasons
colleagues
why I do this.
we should
Yeah.
not get overconfident about the knowledge we've acquired and judge our colleagues that haven't acquired it yet or aren't even curious about it. Because where
Mhm.
were we 10 years? Where was I, 15 years ago? I couldn't have told you any of this. None of it.
Right.
And so should I be
Same.
judgmental of my
Right.
colleagues that don't get it? But I do get a little miffed when colleagues just think they know it. You know, the greatest obstacle to discovery isn't ignorance. It's perception of knowledge. That's the greatest obstacle to discovery. You think you know everything. And you and
Mm-hmm.
I are still hungry to learn more, and we're still studying
Right.
and trying to help
Right.
our colleagues along. I don't know if you know what happened in Chicago a couple weeks ago, but we had a 3-day
No.
pediatric airway course at the American Dental Association. And the president
That's
of the
beautiful.
ADA came in halfway through it, and we thought he was just going to say, hi, welcome, nice to have
Mm-hmm.
you here. Oh no, this guy could have given his own lecture on how he understood the importance of what we were lecturing about, pediatric airway health, as being a component of oral health. It's a shared
That's
domain. Anything
beautiful.
above that, above the clavicles, is a shared domain.
Mm-hmm.
The airway is a shared domain
Mm-hmm.
with medicine. It's not
Mm-hmm.
exclusively the territory of the ENT or the rest or the sleep doctor. No, we all have to work together, including ILBC, doulas, just midwives. Oh my gosh, myofunctional therapists.
Mm-hmm.
You're also a
Yep.
myofunctional therapist, aren't you?
No,
Oh, you're
I've
not. I
taken the
thought you
course,
were.
but I don't really practice that. No,
Okay,
no.
but you
I leave that
understand the
to my
importance of it.
colleagues.
Yeah,
Yes,
yeah.
yes. I definitely I've been exposed to the course, but I don't feel proficient enough. But
I was asked to deliver 5 lectures over the course of 2.5
uh-huh,
days by Dr. Steve Carstensen, who is a liaison with the American Dental Association. Guess what my
uh-huh,
opening lecture, I was, he asked me to give the first foundational talk on a
uh-huh.
Thursday afternoon. You know what it was about? What is missing from professional education and the curriculum? Just what you brought up. We didn't learn this
Mhm,
stuff in our training. And
mhm,
one of the first things I talked about is anthropology, nutrition, and what else? Just that
breastfeeding?
malocclusion and no, and
Breastfeeding?
behavior guidance is that
Mhm,
who can deal when I say early malocclusion, I don't
mhm,
mean early like, before they're teenagers. Early is a defined term in the Academy of Pediatric Dentistry's guidelines for tooth decay. Early childhood
mhm,
caries means cavities, any cavity before the age of 72 months old, 6 years old.
mhm,
So we
mhm,
introduced the whole concept of early childhood malocclusion. Bad
mhm,
bites that will not get better, they will not self correct after the age of 6 years old or 72 months. So
mhm,
why would you wait to fix
mhm.
them? Because
Right,
most orthodontists get no training in how to deal with an anxious child. They say, what if they won't open their
mhm,
mouth? They're too young. You don't want to burn them out. You don't want to use up the orthodontic benefit. Wait till they're older. Wait till they have more permanent teeth. That's like an ophthalmologist saying, okay, your 4-year-old's nearsighted. Why don't you save some money? You don't want to go through 6 different pair of glasses before they're driving a car, even though it'll help
right,
them
right,
have a better quality of life and not have neurological problems. Why don't you wait until he's almost blind,
right.
and then give him glasses?
Unfortunately, yeah. In my in taking care of new families, I hear so much um well, not enough emphasis on prevention of what's going to happen next. I mean, if I have a baby that comes to me that's having trouble breastfeeding and they have a torticollis or their head shape is off a bit, and I say, well, what are your other providers? I'm not the pediatrician. I can suggest, I can educate, but they're looking to their pediatrician for guidance. And what they'll get from the pediatrician is it's not really bad enough to do anything yet, and that just like blows my mind because I know there's lots of things we can do. So that idea of prevention, so your practice as a dentist focuses on intervention in an earlier age group, correct?
Well, first risk assessment. And that's when like at the
Okay.
ADA, I emphasized there was hundreds of people there. And online,
Mm-hmm.
this is going to go all over the world. It was a smashing success. And really, what I say, you have no obligation to treat anybody, you need to do risk assessment of children that are at risk for orofacial myofunctional disorders, malocclusion, and sleep and breathing disorders. That is really, and then, like you said, you need to collaborate. Now, my first course usually is to find out who the child's primary care physician is and primary care dentist. We don't say general dentist anymore. Most kids, most children dental patients are seen by what we used to call general dental practitioners, family dentists. No, we call them primary care dentists now. As a pediatric dentist, I'm a primary care dentist and I'm a specialist. Many of my patients are not my, general pediatric dentistry patients. They just come to me for the orthodontics. Okay. Well, when I need to communicate with other health care professionals, such as yourself, such as a pediatrician, such as a allergist, such as an ENT, such as a sleep doctor, do you know who I contact first? The primary care dentist and the primary care physician. I want them to know, and I want their input as to, do you have any preference for whom I might refer this child to who has enlarged adenoids, has dark circles under his eyes, he wets his bed? I want to make a referral, but I want to do it in conjunction with the two of you. And then you're involving the other primary care people that care about this child's not just acute health, but long-term health and quality of life. And then, oh my gosh, you're a dentist? You're also a sleep medicine consultant at Lurie Children's Hospital? I had no idea. I thought dentists just filled teeth. So that's a way. I didn't know what an ILBC was. This is a way to get yourself known. Target the primary care people, the primary care dentist, the primary care physician. It should be everybody's first step after you have performed risk assessment. You as a healthcare professional, Lisa, really have a tremendous opportunity, if you will, if not responsibility, to perform validated risk assessment on a child's airway competence. And you're already doing that. I know you are. But who knows that everybody should be doing that? If you see kids, you should be performing at least risk assessment and then leave the definitive diagnosis and treatment to the people who actually do the kind of work. And there's more and more people being trained. Orthodontists say wait till they're, 7 and I'll look at them by then. But probably wait till there's more permanent teeth. Wait till the condition gets more severe is what they're saying. And if a parent says, well, why wouldn't you treat it now? Just sit back and wait for their answers. See if you hear something that makes sense to your instinct. And I really say that to parents. Nobody knows the child better than the parents, especially the mom. Maternal instinct is a little bit different from what people with the Y chromosome have. It just is. And I have had, Lisa, you wouldn't believe how many people come to me, and the mom, usually the female adult caregiver, is what most pediatric dentists their first encounter is with. They stamp their foot and say, I thought so. In other words, I've been marginalized by everybody who, I think there's something wrong with my kid. And nobody has been able to do this, and they appreciate me because I go through the science. They need to hear the science behind it. And I need to legitimize my plan.
Right. I have the same experience in my office on a daily basis where the parent is bringing, the mother is like, I know something's up, and everybody says everything's okay, but I know something's wrong. The latch, I've never breastfed before, but I don't think this is how it should feel. This is, and everybody's been gaslighting her and telling her it's her fault or her milk or her nipple shape or something going on, and she feels beaten down by the system. And then I see lights going on in her eyes, like, wow, yes, that's what I thought.
And tears coming out of them.
Right?
I've had moms and dads that start to cry because, oh my God, something could have been done earlier. And I end up having to comfort them. It's not your fault. You've been marginalized. And look you're here now. That's what you got. Right. You have to look forward. You're here now, and we can do a lot for your kid. And I
And then do
show
you go through like, yeah, family history and they start saying, "Oh, my husband snores
them. Yeah.
and he couldn't breastfeed and he's always had a lisp and this happens and that happens." And the connections start going on and then they start to, "Oh, wait, I have a toddler and he couldn't breastfeed and now
Yeah.
he's in speech therapy." And it's just like, wow, it's all connected. But I get all of, what we're trying to do. Um, I was thinking about it before we came on. I was thinking about, like, sometimes when we talk about all the things that are, like, all the setup for the things that are going, quote unquote, wrong with our development.
Hmm.
I was wondering if we could talk about what we can do on an individual basis for prevention from birth, or maybe even beyond, before, and then a population perspective of that. So on an individual basis, if you were talking to a pregnant woman,
Hmm.
what would you ideally tell her about what would make the ideal situation for her
Well,
child
first
at
of
this
all,
point in history?
you left out half the human race there. Um, I call them pre-pregnant women and pre-pregnant fathers. Okay,
Mhm.
preconception.
Mhm.
Women get all, oh, of course you shouldn't drink. The alcohol, interrupts the synapsogenesis of the population of the frontal cortex of synapses, and you have to, uh, mom, protect your egg, and
Mhm.
and they should. What about dad? How about protecting your
Mhm.
sperm? Okay, women's ovum, women's eggs start to develop when they're in their mommies. Okay, grandma
Mhm.
has to do things that can affect her ultimate grandchild. Dads have to do things to make sure they're passing on good sperm, but nothing is said about men. There's very little talked about. So
Very
I
good
have two
point.
daughters. I raised them that way. My wife and I, she did most of it, but we supported one another in that whole concept of, when, if you decide to have children, you must demand not just of yourself, but of your partner. That this is you have to take care of preconception. And certainly, you know, have you ever heard of something called gestational apnea? Most people don't even know about it. Gestational diabetes, of course I know that. Preeclampsia,
Mhm.
gestational hypertension, of course I know about that. How about gestational apnea? Google it. You'll find a ton.
Mhm.
All right. Women who don't sleep and breathe well during gestation,
Mhm.
that can impact the baby's jaw and face development. It's a hypothesis,
Wow.
but there's support
Mhm.
for it. A good hypothesis first has to be not provable, refutable. You have to be able to tear it apart. And you have to do your best to try to find holes in your hypothesis and come up with support for it. And this is a
Mhm.
testable hypothesis that women who don't breathe well, and an experiment was done in the 50s and 40s and 30s. It was called smoking. Winston
Yes.
cigarettes used to advertise a win-win, the wonderful taste of Winston, and a smaller baby, easier delivery. They thought
Mhm.
that low birth weight small kids was a good thing. The cigarette
Yeah, I'm
companies
a
did.
I'm a product of that. So
Yeah,
my mom was told not to stop smoking or having her nightly scotch
there you go.
because they didn't want her to gain too much weight and have a big baby.
Well, you turned out all right.
S
Look at you. I mean, come
Well,
on.
you know what?
Come on.
My jaw is not all right. Absolutely
Yeah.
not,
Well, mine either.
so that was the start of it.
I need double jaw surgery too. But
Yeah.
what the point is with the whole smoking thing and having a smaller baby, not just lower birth weight and not just long bones being smaller. Why would
Mhm.
it just target the long bones? Why wouldn't it target the
Mhm.
craniofacial respiratory bones? It does. You can see it
Mhm.
on mid gestational ultrasounds. At 20 weeks, you can see retrusive mandibles. We can measure them.
Mhm.
It's called the inferior facial angle. We were going to put this to an orthodontic resident to do her thesis on, and it got torn. They said no, we're not going to do that at a major university. It was the biggest
Wow.
disappointment for me. We had it all lined up. We had a sleep doctor from Harvard, and they wouldn't accept it. So
Right.
anyway,
I have a theory about the connection of sleep apnea and preeclampsia, which we know that there's a connection between dental health and maternal health and infections and even high blood pressure from dental infections. That there is research for that, but also the preeclamptic aspect, because if you're not breathing right, of course your blood pressure is going to be higher. The pressure in your veins, your body is working harder in half your lifetime when you're supposed to be asleep. And how could that not affect your blood vessels and the way your body reacts?
That is magnificent. I mean, I'm listening to you so intensely right now. I had never thought that gestational hypertension could be related to gestational apnea. I want you, please, to think about this with me, and just do a search. I can send you some papers on gestational apnea, but you have formulated a very testable hypothesis. So I would, I'd like to explore that with you. I got a lot on my plate right now, but if you could just sort of stay curious about that, because I think there's something to it.
Yeah, and the reason why these connections aren't made in general is because, like you were saying before, not only don't we learn everything in school, but what we learn in silos, we don't learn together. And so what I know about midwifery and taking care of pregnant women intersects with what I know about, now I'm learning about dental health and airway and everything. So I'm in a unique position where I see different views. You're in a unique position, which is why your work is so interesting, that intersects the nutrition, the dentistry, the airway. So all of us who have exposure to different disciplines have a different perspective and different ideas on what works, right? And why things happen.
I'm absolutely never been happier being a dentist, because I just don't do anything but this aspect of oral health. Dental health is a component of oral health. We're called dentists, meaning, you just take care of teeth, right? Well, no, we take care of where the teeth reside and what they're, what the jaws are connected to, the airway. So no, I haven't done restorative dentistry in a long time. We still have decay in our practice, but not much. We really emphasize healthy eating and try to reinforce what parents really want for their kids. So I've really got to go now, Lisa. I've got another call, but this is fascinating, and maybe we can do a part 2.
Absolutely.
And after you've done a little, exploring on preeclampsia and gestational apnea, that would be a neat talk to do together.
Yeah, that would be fun. Thank you so much for your time. I know how busy you are, and I appreciate every moment you gave us today. Thank you so much.
Thank you. I'm honored to have been asked to do this. You're a force. Right. You're a force.
All right.
Okay, I'll see you later. Bye-bye.
Bye-bye. Thank you so much for listening to this week's episode of the Tongue Tie Experts podcast. Check out the show notes for useful links about the topics we discussed and for ways to follow us on social media. Please subscribe to us on your favorite podcast app. And if you enjoyed listening, we'd love it if you'd rate, review, and share with your friends and colleagues. Thanks so much. Bye-bye. Tongue-tie cases can be confusing, but what if you had a place to ask questions, learn from experts, and connect with professionals who truly understand? That's exactly what you'll get when you join Tongue-tie Experts Insiders. It includes monthly online meetups with me, Lisa Palladino, expert guest speakers sharing the latest research and best practices, a private community of other professionals ready to support you every step of the way. For just $19.99 a month, you'll never have to navigate tongue tie cases alone again. Join the community today. Your future self and your patients will thank you. Sign up now at tonguetieexperts.net/insiders.